presentation covers the normal physiological events of the third stage of labour and illustrates a physiological birth of the placenta and membranes. After the birth of the infant, the posterior pituitary gland continues to release oxytocin to maintain strong contractions within the myometrium. These rhythmic and intermittent contractions aim to empty the uterine cavity of all products of conception. The puerperium begins immediately after the placenta and membranes are birthed. This cross-section of the uterus just after the baby has been born shows that the placenta and membranes are still adhered to the maternal circulation. The maternal surface is layered. The wall of the uterus is made of a myometrial layer of muscle formed from smooth myometrium. Blood vessels run through the myometrium into the endometrium, circulating blood to the placenta, membranes, and the infant while in utero. This profile shows the outline of the decidua basalis and the segments of approximately 35 cotyledons. Fetal capillaries lie within the chorionic villi. The intervillous space is the point at which the maternal and fetal circulation combine but do not mix. The intervillous space is a cleavage between the maternal and fetal surfaces, filled with maternal and fetal capillaries and chorionic villi of the placenta. It is not hollow as seen here. In this illustration, structures have been limited for clarity. The cotyledons of the placenta extend into the maternal surface through the decidua basalis to receive nutrients and gaseous exchange via the interstitial fluid. There are two layers of membranes, the amnion and the chorion. The amniotic membrane encased the amniotic fluid containing the infant before birth. The chorionic membrane is made of chorionic villi but becomes compressed between the amniotic membrane and the uterine wall. The umbilical cord varies from 45 to 65 centimetres in length and is surrounded by Wharton's jelly. It contains 3 blood vessels, 2 arteries and 1 vein. The umbilical vein carries oxygenated blood from the placenta to the fetus, while the arteries carry deoxygenated blood from the fetus to the placenta. After birth, the vein collapses, while the arteries retain their structure. There are several types of cord insertion, including central insertion, battledore insertion, and velamentous insertion. The average placenta weighs approximately 1/6 of the weight of the infant at birth. Surges of oxytocin lead to strong contractions, causing the uterine cavity to contract, decreasing the surface area of the myometrium and the size of the uterine cavity. As the myometrium of the upper segment of the uterus contracts, it becomes thicker, and the lower uterine segments become thinner. The changing shape and the shearing forces detach the placenta from the shrinking uterine wall. As the spongy layer of the decidua is exposed, blood vessels in the decidua basalis bleed, and a retroplacental clot forms. This creates pressure on the placenta and encourages further separation. The placenta may dislodge and separate in different ways. In a common separation method shown here, known as the Schultz method of separation, the placenta folds in on itself centrally. Once the placenta and membranes separate, a substantial layer of the endometrium is removed, leaving a sinus in the uterine wall, which has the potential to cause a hemorrhage if physiological processes fail. Oblique muscle fibres surrounding the blood vessels contract to seal the torn ends of the maternal vessels and prevent hemorrhage. Strong rhythmic contractions expel the placenta physiologically. Most women feel the urge to assist the process and instinctively bear down to push the placenta and membranes from the vagina. A physiological third stage can safely take up to 1 hour if there's no active bleeding. If the birth occurs in a hospital environment, clinical guidelines recommend administration of an oxytocic medication if the placenta and membranes have not birthed after 60 minutes, or if bleeding is profuse. Alternatively, an actively managed third stage involves the administration of an oxytocin immediately after birth, which leads to the expulsion of the placenta and membranes within about 5 minutes. Hemostasis is achieved in 3 ways to reduce bleeding. Firstly, ischemia occurs when the smooth oblique myometrial muscles of the uterus contract, shortening and thickening as they contract to occlude blood flow to the placental site. Occlusion of the myometrial blood vessels reduces blood flow and achieves hemostasis. Secondly, as the uterus contracts, the maternal sinus reduces in size and the pressure from opposing uterine walls forms a T-shape within the uterus. Finally, the coagulation cascade involves the formation of a platelet plug. Then prothrombin, thrombin, and fibrinogen are released into the blood to form a clot. If a segment of membrane or placental tissue is left inside, the uterus may be prevented from contracting fully, which can lead to hemorrhage. If the tissue is left inside with no blood supply, it will become necrotic and could lead to puerperal infection and sepsis. Contractions persist rhythmically for 24 hours after the birth of the placenta and membranes. The uterus will continue to contract at a rate of approximately 1 centimetre below the umbilicus a day until the uterus is the size of a pear. The uterus never fully returns to its pre-pregnancy size. In multips, these contractions may cause after-birth pains, especially after breastfeeding, as sucking stimulates production of oxytocin. In the first few hours, the blood flow, referred to as lochia, will be bright red, a colour known as rubra. Over the course of the first few days, the uterine sinus will scab over as circulation and bleeding ceases. The lochia will turn pale red or pink, known as serosa. The serosa lochia contains leukocytes and dead cells. As the scab dries, the decidua regenerates over the following 5 to 10 days. Phagocytes digest the dead tissue cells. The lochia at this stage is brown and eventually turns white. This lochia is referred to as alba. The decidua basalis will regenerate and thicken in anticipation of the next pregnancy or menstrual cycle. Ovulation will occur in response to follicle-stimulating and luteinizing hormones, estrogen and progesterone. The woman should be advised of her returning fertility and appropriate use of contraception based on her feeding method.